Hello, Ian Engelman here. I've given this lecture several times now in different formats, and I thought I would put it all into a video so that it can be easily shared. When I first gave this talk, I called it Medial Column Ligamentous Failure. And I was surprised to learn that some of the participants arrived thinking that we were going to be talking about the knee joint. So then I changed to Medial Column Breakdown, which did a little better, but really when it came down to it, calling this talk Categories of Foot Failure communicates the idea in the easiest way. So you'll see that the image here has a blue delineation between the medial column and the lateral column. Most of what we're going to be talking about today is the medial column. And our first slide shows three different types of medial column breakdown. And so we're going to talk about how each category might be identified and which ligament would be responsible. It seems that we don't possess the language to adequately articulate the differences between these categories of pathologies. When I was in school, we learned the anatomy through two-dimensional images such as this. Currently, the methodology of measuring the pathology is with x-rays. The problem is that with x-rays, they're not exactly reproducible. So different x-ray technicians will take x-rays from different angles, resulting in different outcomes. Slices are better, but what they do is they require the practitioner to reassemble all these slices in their mind's eye to figure out what that three-dimensional image looks like. Back 1,000 years ago, when we were humans looking up at the sky, we would see a two-dimensional image of these stars in the sky, and we'd see some stars ride through the other stars. They turned out to be planets, and that would be, of course, the zodiac. But human beings saw it as a two-dimensional image, and how could they think anything differently? That's what it seemed like. Well, when the telescope was invented back in 1608, everything changed. All of a sudden, we had this understanding that it wasn't a two-dimensional image at all. It was a three-dimensional image. And now we could see that not only do we have stars within our galaxies, but there are stars outside of our galaxies, other galaxies, and there are planets that rotate around our sun. So all this was discovered and understood because we had the three-dimensional understanding rather than the two-dimensional understanding. I live in Maine, and so here we have a lobster that we caught, and it's oversized, and you can see from the size of the hand and from the gauge right here that this is definitely a lobster that's too big. And from this image, it's really hard to tell and get a really good understanding of just how big this lobster is. But when we go to the three-dimensional image here, you'll see that the lobster now takes on a totally different look. When you see the different parts of the lobster coming in front of other parts, and you see that the rotation in space, all of a sudden you have a totally different appreciation for how big this lobster is. One of my major points is this is exactly what's happening here in our industry. That is, that two-dimensional world that we've been looking at has been inadequate. Now that we have three-dimensional rendering, it's a total paradigm shift. And now we have an incredibly different way of looking at the pathologies of these feet and measuring them in an accurate way. So what's happening here? This isn't exactly three-dimensional imaging, is it? We're not looking through prism glasses or glasses that have one red eye and one blue eye where you're giving different images to each eyeball. You're not really getting that stereogram image. What's really happening is that you're getting kind of a temporal averaging. When you show a video and you're able to rotate something in space, you have an understanding, a much bigger appreciation for how the relationship of the bones are with one another. Kind of like a baseball player. If you ever notice a baseball player going to catch a ball, the baseball player will move their head back and forth. And the reason they're doing this is to get a better sense of how far that baseball is away from them. And that movement back and forth of the head gives them an extra advantage because they can use their brains to zero in on the distance that object is away from them. That is the baseball. Curvebeam, who makes the PEDCAT machine and whose images you just saw through the CubeView software program, is the company that's got the best possible 3D imaging available. Why is that? because it's weight bearing, which is huge. Of course, there's no sense in analyzing a foot that's not in the weight bearing position because, after all, we're in the weight bearing business. We don't really care much what the foot does in a hanging position. When we have compared the analysis of a X-ray versus this kind of modality, what we find is that it's very reproducible. That is, the PEDCAT machine can have the same result over and over again versus, say, the simulated weight bearing. Now here's an example of simulated weight bearing. It looks a little scary, kind of like a medieval torture device. You'll see that they've got weights that are through pulleys that go over a harness that are over the shoulder. They're driving the person into that platform in a horizontal position. That's not exactly what the person experiences during weight bearing. You can imagine if you were in this, how you'd be tensing up and protecting yourselves from being crushed. I appreciate that these clinicians understood that weight bearing simulation was important to make an analysis of what actually happens in that circumstance. It's just that this seems to be inadequate. When we look at these images here, and you carefully look at each one of these pathologies, you can see right away that these are clearly different types of medial column breakdown. Medial column breakdown has been described with all these different terms, and each profession seems to have a favorite term or two. I'm an orthotist, so I tend to use the word internal rotary deformity. And internal rotary deformity worked for me for a long time, and I understood that there was this closed kinetic chain of pathology when the tibia rotates and the forefoot abducts and the hindfoot goes into valgus and maybe even have genu valgum. It all seemed to connect. However, after a while, I started to recognize that not every medial column breakdown case displays internal rotation. The physical therapist tends to use the terms pronation or midfoot collapse to describe what's happening here. And those are good generic terms, and everybody has an understanding of what the problem is. However, it's not specific. Podiatry has gone in, I think, the wrong direction. That is that they've hung the whole pathology on this one muscle and tendon group from the posterior tibialis tendon. Now, they describe it as posterior tibial tendon dysfunction, which really doesn't make any sense to me. It's not likely that the whole architecture of the foot is being upheld by this one small muscle. Now, I can understand if the collapse of the medial column stretches that tendon, you would have tendinitis. That makes sense to me. They tend to use the term posterior tib to describe this problem as a kind of a big generic term. Orthopedic surgeons prefer the term adult acquired flat foot. They also tend to talk about the hypermobility of the first ray. Pes planovalgus is a term that us orthotists tend to use. But it's interesting, they've decided that they need to have stages, and they talk about the different stages of, I guess, adult acquired flat foot. And I do think it's worthy of consideration in terms of describing the degree of the deformity. I just don't see that it's anything more than that. Meary's angle tends to be a good measure of how the talus lines up with the first metatarsal. And it's a nice way of measuring to see just how much of a breakdown there is along that medial column. However, it's a two-dimensional image and a two-dimensional measurement. It doesn't at all describe how rotated that talus is, and you don't know if that talar head is popping out in front of us or not because it's just a two-dimensional image. Calcaneal pitch is another two-dimensional metric, and this does describe the angulation of the calcaneus. The weight-bearing study group took a look at the different types of techniques used to measure hindfoot valgus, and there were 4 different techniques used for the same patient, and guess what? They had 4 different results. Why is that? Because they're using a 2-dimensional measurement system to try to describe a 3-dimensional problem. What's really exciting is now that we have 3-dimensional rendering, we can get reproducible outcomes and measurements for these types of pathologies. One such measurement system or metric that's being used is called the TALAS, torque angle lever arm system. Basically what this describes is a pyramid, and they take the center of gravity through the talus and position that over the triangle that's made from the 2 metatarsal heads in the calcaneus. This is a very reproducible metric that will tell you just how stable that foot is during weight bearing. And it's automated software-based measurement, meaning the human beings are cut out of the equation and the software, the computer, will decide how these measurements are constructed, and it will do that same construction every time. Here are some two-dimensional metrics that I like. However, it's used in a three-dimensional way, meaning you would take the slices and you'd move the slices back and forth until you found the very lowest point of the navicular, say, and then you would measure the navicular to the floor distance, or the medial cuneiform floor to the floor distance. To me, these are meaningful, reproducible metrics that are only being able to be constructed through a three-dimensional analysis like this one that Curve Beam has been able to produce. Another one that the orthopods are taking a look at right now is the inferior facet, the talus, and how that angulation can be different with different people. Again, a reproducible two-dimensional image, but only possible because you've got the ability to move that slice in 3 dimensions along that third axis. It's great to finally have reproducible metrics of these types of pathologies. The missing element is that these parameters don't describe the type of pathology, and that's what we would like to try to accomplish. You can see from these descriptions of the different stages of posterior tibial tendon dysfunction that they are all very similar. So let's take pain, for instance. Stage 1, pain. Stage 2, pain. Stage 3, pain. Stage 4, valgus deformity of the talocrural joint. Well, you can't tell me that there's no pain in stage 4. Actually, I would bet that those that are in stage 4 probably have more pain than any of the other stages. Let's take another description. Let's take the top one, for instance. Stage 1, let's see, tendosynovitis or degeneration of the tendon. Okay, I get that. Elongation and degeneration of the tendon, that would be stage 2. Stage 3, elongation and degeneration of this tendon. Hey, wait a minute, that's the same thing. Stage 4, some presentation as in stage 3, with the inclusion of valgus deformity of the talocrural joint. Well, there's definitely valgus deformity in stage 2 and stage 3. So when you really start to look at these stages and the definitions that are presented to us to this day, they start to look very different when you start to bifurcate them in meaningful ways. Now, I'm not saying that there's no value to describing the degree of deformity. That makes sense to me. What doesn't make sense to me is to lump them all into this idea that it's somehow the posterior tibial tendon that's causing all these problems. That doesn't make sense. And moreover, I think we can do better. I think we can better distinguish the types of medial column breakdown than these types of stages. Okay, so where are we now? If that one is stage 4 and that one is stage 4, how could they both be stage 4? All right, if that one's posterior tib and that one's posterior, but that doesn't look like posterior tib, that's definitely not the same as that. All right, so IRD. Okay, I can see some rotation in that one, but definitely no rotation in that one. That looks different. So when you start to try to use the language that we've all been using in our various professions to describe this pathology, and you look at the different of characteristics that are out there, it quickly falls apart. For me, I think the literature can be misleading or definitely oversimplified. And it's often described the foot as like a chain, or the foot is like a bridge or a sling, even a gyroscope I've heard of, 3-legged stool, hinges or set of hinges. Why are we trying to take the foot, which is a set of bones and ligaments, and trying to describe it as if it's an everyday item? Why not describe the foot as a set of bones connected with a set of ligaments? Those bones being, on the medial column, tibia, talus, navicular, medial cuneiform, and first metatarsal. Why don't we talk about the ligaments that are responsible for the architecture and the maintenance of that structure, as the deltoid ligament, the spring ligament, the CalcaneoNavicular ligament, or the tarsometatarsal ligament? For at least the purposes of this discussion, let's take this old language of medial column breakdown that's been misleading us for all these years, and let's, for at least this discussion, trash it and look at something and try to do something better. For the purposes of this discussion here, let's for a minute take away these old descriptions and this old language that's been misleading us for all these years. And let's remove that and let's reset for a second and ask ourselves, can we do better? And this really comes down to two basic ideas here. That is that the current terms for medial column breakdown seem to be insufficient, and that now that we have 3D rendering, it allows us to really understand exactly what's happening with the relationships with a three-dimensional analysis. These two ideas come together with the thesis statement that the root cause of medial column breakdown is ligamentous failure, and that different types of ligamentous failures will determine different categories of medial column breakdown. So let's look at the ligaments a little bit more carefully. Here is the body's exhibit, the medial column. You can see it's a fibrous mass that goes from the distal tibia all the way to the first metatarsal head. When we strip that away, you can see that we've got the deltoid ligament that's very clearly identified here. And we've got this ligament, you can see the spring ligament, and then you can see this ligament that tends to kind of move from one bone to another along the plantar surface of the navicular, first cuneiform, and first metatarsal. Now this ligament is better defined by the individual segments that are connected each time it goes from one bone to another. Now, again, for purposes of this discussion, we're going to use the term ligamentous failure. Now, some would call it stretch or attenuated or partial tear. A complete rupture, of course, is different. But the point is that when we see these shapes, it's pretty obvious that it's a specific ligament that failed and produced these shapes. So now I present to you the big picture. We've identified 5 different types of categories, and these are categories that we've seen over the 15,000 patients that have come through our doors. And each one of these types of pathologies we're surmising is a result of a certain ligament failing. First, we'd like to look at what a healthy medial column is, because only with that can we start to determine what's not healthy. Here we see, when we play this video, from the posterior we can see nice alignment. We see the calcaneus and the heel pad squarely underneath the weight line. As we rotate it and take a look at the medial side, we can see nice high medial malleolus. The plantar surface looks to have a normal footprint. When we strip away the soft tissue, you can really see and imagine the weight line coming through the tibia, right through the talus, right through the center of that calcaneus. Doesn't seem to be any hindfoot varus or valgus. Both the medial and lateral malleoli are nice and high. From the sagittal viewpoint, when we strip away the soft tissue, you can see this nice straight line. We talked about the Meary's angle before. Nice straight alignment of all the bones of the medial column. This person is probably young and lightweight. From the top-down view, it seems as though we've got a standard distribution of pressure plus an arrangement that looks very normal. Without any better example, we're going to call this a healthy medial column. We're going to present these categories from proximal to distal: lateral foot dislocation, talar escape, mid-column collapse, Lisfranc breakdown, or lateral column flat foot. Each one of these types of pathologies tends to have a ligament associated with it. We'll be going through each one. Lateral foot dislocation seems to be caused by a failure in the deltoid ligament. When you take a look at this video of the three-dimensional rendering, you can see that the foot is lateral with respect to the weight line of the tibia, and that the weight of the tibia coming through the talus is actually outside the base of support. With these types of feet, you have hindfoot valgus, but you don't necessarily have forefoot abduction. When we strip away the soft tissue, you can see that the alignment of the calcaneus is very lateral, and that there doesn't seem to be anything underneath the talus to support the talus. The identifying features with this pathology tend to be valgus, hindfoot valgus, lack of forefoot abduction, and a medial weight line. Next, we have talar escape. This is likely due to a weakness in the spring ligament or the plantar calcaneonavicular ligament. Here, with this image, you can see that it connects the calcaneus to the navicular and holds that talar head in place. This video will demonstrate to you how the talus is prominent. You can see it, the talar head just distal to the medial malleolus, and the distance between the talar head and the medial malleolus is a lot less than the distance from the navicular to the medial malleolus. When you take away the soft tissue, keep your eye on that bulge, you can see there it is, the head of the talus poking right out. Identifying features here is that you can easily palpate the talar head, which tends to be 3 centimeters from the medial malleolus. Working our way down, we have mid-column collapse, likely due to the weakness in the plantar calcaneonavicular ligament. Here's a description of the ligament that connects the navicular to the medial cuneiform. This is kind of more of a standard type of pathology, and you can see the bulge in the midfoot. And we're calling this mid-column collapse, not midfoot collapse, mid-column collapse. And that's because it's right in the center of the column. When you take away the soft tissue, you can see that it's often associated with a very prominent, substantially prominent navicular. Now, the navicular is always prominent, just like the medial malleolus is always prominent. But in these cases, it's substantially more prominent than usual. You are also likely to have forefoot abduction and a midfoot bulge. Working our way down once more, we have the Lisfranc breakdown. The Lisfranc joint is well known, and the plantar tarsometatarsal ligaments are the ones that seem to be failing in producing this outcome. Here you can see that small ligament in the plantar surface connecting the medial cuneiform to the base of the first metatarsal. What's interesting here is you have this obvious bulge and weight-bearing element right in the distal part of the medial column. It's often associated with a fat pad that can be manifested because of that weight bearing, almost like the fat pad that you would find on your heel. A lot of hindfoot valgus and a lot of forefoot abduction are associated with this type of pathology. What's curious is that there tends to be this fifth type of category that doesn't fall neatly into the medial column failure description. Here we see a description of the long and short plantar ligaments, and you can see that the long one connects the calcaneus to the base of the fifth, and the short one connects the calcaneus to the cuneiform. Both these ligaments are responsible for the architecture of the lateral column. My guess is that it's the lateral column that's failing in these feet. That is, the medial column is perfectly healthy. It has good alignment both in the sagittal and the coronal planes, yet it's totally obvious that the foot is very flat. Here you can see a very flat foot. Yet when we strip away the soft tissue and we take a careful examination of, say, the sagittal view, the alignment looks good. A little bit of a Meary's angle, but not bad. And then when we look at it from the posterior vantage point, we see also that the hindfoot is neatly underneath the weight line that tends to go right through the shaft of the tibia and through the talus. So there's not a lot of hindfoot valgus or varus. The malleoli tend to be low, and maybe there's some calcaneal plantarflexion with these cases. But since it's obvious that the medial column seems to be in healthy architectural form, it must be the lateral column that's failing. When those ligaments fail, they tend to lower the whole foot down, and the angulation of the calcaneus declination angle is reduced, and the whole foot is lowered, yet there doesn't seem to be any other manifestation of pathology. So the identifying features of these types of feet is you have good hindfoot alignment, no valgus, no forefoot abduction, and no talar head or substantial navicular prominence. Over time, I think it'll be obvious to everybody that three-dimensional rendering is going to be a game changer. We're going to have better, more reproducible results that we can depend on for the measurements of these types of pathologies. And back to our original, instead of describing each one of these pathologies as, say, posterior tib, why not use better language that's more descriptive and use talar escape, mid-column collapse, and Lisfranc breakdown? Distinguishing these categories is very helpful. Keep in mind, however, that some feet may have more than one type of pathology or a combination of two or more. The 4 points I'd like to leave you with are these. It's important to have a deep understanding of the problem at hand. That's the only way you're really going to solve a problem. And descriptive language tends to be better than diagnostic language. Also, that the architecture of the foot is primarily from the ligaments, and that the tendons and muscles are not responsible for the architecture of the foot. And lastly, the three-dimensional rendering and the power of this new technology is going to change everything in terms of our basis of measurement and quantification of these types of pathologies. I hope you've enjoyed this presentation. It's been fun for me as somebody who's interested in the topic to investigate and understand better what's actually happening. You can see my article in the Lower Extremity Review, January 2018. And with that, I bid you farewell for now.